Hey everybody, welcome to the Fire It Up with CJ show. Today we have Chris Kerr, who is here talking about his book, Death is But a Dream, Finding Hope and Meaning at Life's End. So um, Christopher is CEO and Chief Medical Officer at the Hospice in Buffalo. So thank you for being here during what I imagine is a very crazy time for you.
Yeah, thank you for having me.
So I wanted to get a sense of how the COVID virus, and is shaping your world and how it's changing hospice care and the world around you.
Yeah, well, a couple of things. There's obviously the societal piece where there's this collective fear, dread, apprehension. Most of our cases came in via travel initially, so we don't have the endemic set yet. So we're kind of braced for this wave of anticipated illness coming. I think in terms of what we're seeing is we're seeing the hospitals trying to understandably increase their capacity as much as possible. So that means the out-of-home models are critically important, that we're taking care of complex and seriously ill patients in place. Um, I think that there's some unfortunate things we're seeing, like in long-term care, where the families aren't getting access to their loved ones, which is essentially another version of a complicated grief that's hard to describe. At a more human level, I think we're seeing the best and the worst. We're seeing a minority of people who, if you're prone to paranoia, heightened anxiety, that sort of thing, you're falling in that direction. Conversely, we're seeing people who are recognizing a great need and want to help and contribute. I see people who, as an attempt to feel some element of control in an uncontrollable situation, are wanting to engage, which is really interesting.
Mm. So I've heard just awful stories about people seeing their loved ones from a pane of glass, not because they can't be with them at the time that they need them the most. So how are you handling situations where someone is clearly approaching their final days, and there's a loved one that's like across, in a piece, I don't even know, on Skype. I don't even know how people are reaching their loved ones.
Yeah, we're trying to serve as ambassadors, as liaisons, and work with the nursing home to get those folks in.
Yeah.
Uh, I think it's one thing to have a general policy that, okay, we're going to limit visitations and congestion, but another thing to separate families from their dying loved ones. So we're actually helping bridge that gap, and most of the nursing home operators are pretty reasonable. I'd encourage your listeners, if they're stuck in that predicament and you have access to a hospice, particularly a hospice inpatient unit, you can transfer the patient out of the long-term care facility into a hospice, because I don't know of a single hospice that is shutting access.
Okay, so then actually when you say they're working as ambassadors, they're not just shuttling information back and forth, they're allowing their loved ones to come
Yes,
in.
they're approaching the ownership. It's one of those things where there's an institutional policy, but is there room to alter the spirit of the intention and get people to actually come into the building? And we're having some luck with that.
Hmm.
So that's one approach. Is have an advocate
Hmm.
is really important, but also if you're hitting a brick wall, is seeing if you can transfer the patient into a hospice care facility that would have more access.
Mm. Okay, so you also have patients that, in addition to patients, you have healthcare workers who, a lot of the people in Seattle who were in the Kirkland facility where a great number of people died, they couldn't leave that facility, so they were taking a shift, which ended up being, weeks long, like the people stuck in the boats, that they were taking shifts that lasted for a really long time. How are your healthcare workers holding up under the strain of not only their potential loss of themselves and then the connection with their families?
I think the latter piece is the hardest, right? Is that they're fulfilling their professional role, but their heart and their fears are somewhere else in the home with their children. There's you see a tremendous amount of camaraderie that is helping to support one another. I think we've got a lot of this wrong. Obviously, the injury here, aside from the virus, is the lack of testing, because we treated these healthcare workers as though they had to stay within an exposed environment, when the reality is the virus is pretty near ubiquitous. and the idea of keeping people protected from it from that level isn't necessarily realistic.
Mm-hmm.
You know, it's it was well intended, but we were dealing with a void of information.
Yeah.
Fortunately,
Yeah. Or lots of changing information as we got it and learned more, it seems like.
yeah. But the only way we were going to have that information is if we had data. The only way we were going to date is if we had testing. So, for example,
Mm.
we have no idea of the number of asymptomatic carriers. So the idea that the only people who are exposed to the sick, which was originally kind of the working theory, is false. You
Right.
go, you in other words, you go to your grocery store and get more exposure than you could walking down a hospital hallway.
Right.
So it's kind of all the paradigms.
Oh, wow. Okay. So, um, now you said in your TEDx video that you've been kind of the topic of dying has followed you throughout your life, and here we are facing a whole society facing a fear of death, fear of loss, of our, of some sort, either a fear of our own lives, fear of losing something that we care dearly about, a human being, our house, our job. I mean, what have you learned about loss, having this topic of death follow you throughout
You know,
life?
I think it's important to separate the sort of loss, the potential loss we're facing now, which is acute, more of an acute loss,
Hmm.
right? Which really doesn't allow one to prepare,
Ah,
to adapt, to gain acceptance, to find
mm,
peace.
mm,
Basically, we're in a defensive posture, a reactive posture, it doesn't allow you to evolve in any way that gets you to peace.
mm.
So if somebody you loved who's healthy were to come down with this, it's like any other acute injury, is that there isn't time, basically.
Right. Yeah, like my dad, and when you're saying acute, I'm interpreting it like my dad who died of a heart attack.
Yeah,
There wasn't a lot of time for me to adjust to his death. I just got a phone call, your dad is dead. So that kind of, is that what you refer
exactly.
to as acute?
Yes, yes.
Okay.
Versus what we typically see in hospice, which is a very different death, which is people have obviously the acuity of the diagnosis and trying to come to terms with that. But the vast majority of people who are end of life after prolonged illness reach a very different stage of acceptance and
Mm.
even grace. And so that I really view the dying process as completely different for most people. This is very atypical.
Mm. And how many people, and you're a numbers guy, so I'm assuming you know this number, but how many people die of acute deaths and how many
10%.
people? 10%?
Mhm.
So 90%, the vast majority of people actually have this time
Yeah.
to actually accept the death. And for those 10%, is there, and I know that you said this is acute deaths are very different. Is there any solace that one can offer people who fall into that 10%?
It depends on the acuity. So let's say somebody has a heart attack like that, and it happens in their sleep. It's one of those events that is, in some ways, depending on the age of the patient and their debility, better for the patient. If you
Mm.
ask most elderly people who have a compromised quality of life, have multiple comorbid illnesses, they're hardly move around because they're arthritis, they're short of breath because they're heart failure. What they would ask for is not a drawn out, dying, decaying process, but they would ask for, to pass in their sleep suddenly. So in those events, I think the solace is this: it's better for the patient, harder for the family, because again, you don't have time to adjust. But when you think about it from the patient's perspective, you realize there is a certain amount of grace to it.
Mm.
That's actually what elderly compromised people wish for.
Mm.
I haven't met the person actually. It's extraordinarily complicated, dependent in care, fully catheters, wounds, who said, give me more of this.
Right.
Uh, it just doesn't happen that way.
Yeah, that actually gives me a lot of peace having had a dad that died of a heart attack because it is, like you said, it's very hard on the bereaved because there's not a time to adjust. There's no last
No,
words. There's just kind of a boom, empty, gone. And then just this kind of chaotic feeling of what has happened,
yeah,
versus if you actually have a longer period of time, a longer period to adjust. but then also a longer time for that person to feel pain. That is actually, as someone who has experienced an acute death of a loved one, that is actually very, very comforting. Um,
And think of it
Thank
as
you.
a parent. If you're a parent, the one thing elders don't want is to burden their children.
Yeah.
They've lived in the notion of support to their children, and they do not want to be a burden.
Mm.
When there's surveys done that are very, very interesting, they ask elderly people what they value most. Guess what's at the bottom of the list?
To be at the
Length
bottom,
of, yeah,
like.
the thing they value less is living longer. So what people want, and that's not they're not death centric or death
No.
crazy. What it is, people want to live as well as they can, as long as they can. But when the terms change and they're compromised, they don't want length of life at the expense of quality.
Mm, that's
It,
actually, yeah, that's interesting. And but it is hard when you see someone who's really young, that hasn't
that's
actually
that's
had that
that's
full life.
that that's so you can't. I don't think you can stratify dying as one universal experience, because I think you're absolutely right. An unfinished life, a life with promise, a life where they still have dependent roles like young children. That's just tragedy.
Right. Let's talk about the other. In the next segment, we're going to talk about the other 90%, those people who actually pass not through an acute death, but just have like a natural process that they're maybe in the hospice and going through that process.
Yeah.
So we've been talking to Dr. Christopher Kerr, who is the CEO and Chief Medical Officer at the Hospice in Buffalo, and the author of a book, Death is But a Dream, Finding Hope and Meaning at Life's End. We're going to talk about his experiences having interviewed 1,400 patients and spent the last 10 years studying the dying process, and talking a little bit more of that in the next segment.
It means so much to me that you're listening to the show. I would love your support in any way by giving me comments below, or to subscribe to the show, or share the show with friends. Thank you again for your support. Love and blessings.